So for our drug of choice project, we chose the opioid morphine and the depressant benzodiazepines. And my name is Madison Trout.
And I am Naima. So the drug that I chose under overbuy category is morphine. As you can see, it is forming two liquids. Two different forms will be in liquid and also in pill as well. My drug is a narcotic drug, so it's for severe pain. I have research is also can be used in 3 different places besides the hospital, which is of course the IV bed, but also for nursing homes and hospice care for nursing homes can be also used to help dementia patients to get restful sleep if they are screaming too much at night, but it must be prescribed by the doctor. And for hospice, it is for it's to help deceased patients transitioning in a smoother way, but also for morphine. So those are the places for my side.
For benzodiazepines, a more common term that people may know is benzo. They're minor tranquilizers that are typically prescribed for anxiety or for people suffering from insomnia. And they are a depressant, and they're normally taken in pill form, which is what this image is on the screen. And we'll now be talking about the pharmacokinetics.
So for my drug, as I was speaking from the first slide, can be in 2 different forms, liquid or pill. So for my side, it gave me more information of if it's using the actual form. So of course, it goes through the mouth. So that's why it says orally through tablets or capsules. So I found out it's a more migraine form into the capsules pill. I'm sorry if I'm pronouncing it wrong. So it goes through the mouth, and for the dispersion process, it goes to the liver first, and that's where most of it is breaking down, especially if it's in large forms. And then of course it gets our central nervous system. As you know, it attached to the main glands in our body area. And then of course for the metabolism, as I was just speaking about, it goes into the blood. So the morphine really stays in the blood for it to get a more relaxing feel. That's how it gets to the muscles. So when someone's going through severe pain, and also that's how it becomes formative addiction because it is going through the bloodstream. So it does lead through urination, just like any alcohol or other drug. But the difference with morphine, that 10% of the drug actually remains in your body. And that is how the addiction is start to build up, because 10% of the drug is still left in your body even if you 90% urinated it out.
And then for the benzodiazepines, similar to morphine, it can be ingested orally with pills, which I mentioned on the previous slide. But a liquid form of it can be produced and injected, but that's not as common. So if someone does take it in pill form, which a common benzodiazepine is Xanax, it's then absorbed into your gastrointestinal tract. But if you do inject it, similar to morphine, it goes to your central nervous system and your brain. Within 1 hour, the peak levels are reached. And again, similar to morphine, it's excreted nearly entirely through your urine.
So for the chronic effects, I use this picture to really broken down because it's really a lot more listed with the short-term and long-term effects. So I just broke it down to some things because a lot of the short-term and long-term effects are really similar to each other. So with this picture, it was showing that there's so much pain into the stomach before you get the digestive system. As you know, our stomach, it tells us if we need to eat, like if our body needs to eat. So the short term, that's how it's loss of appetite, because you're now not depending on your natural resources that your body is looking for. So that's how weight loss is also progress. So you're not really eating or drinking much. So that's where the dry mouth comes into the play. So, nervousness, weakness, that's all that ties in with the stomach pain, the chest, even good to the chest pain, because of course, that's where your heart and it's like connected to the body. It's like getting messages that something is not right. And also it becomes very painful when you have your periods as well. Like it's not like pleasing. It's not like a regular period, but it gets to the point where it's not functioning well, and then you will have a hard time also having sex. So morphine is very crucial to the body when it becomes highly effective with addiction.
I also did not list all of the effects because there's numerous, but as you can see in the short-term effects, these are the more positive outcomes that people look for when they abuse a drug such as this. They want to get the calmness, which is shown in the muscle relaxation, the sleep, the anxiety reduction, and those are more positive reasons that people will take this. Some of the few negative ones you can see: slurred speech, impaired judgment. But then when you move over to the long-term effects, that shows the more negative outcome. It can lead to weight gain or ultimately personality change, memory loss. So in the moment, people are not worried about the negative effects because that's not what happens right away.
So for the painful tolerance, as you can see, it become potential for tolerance. I'm sorry, not painful tolerance. Potential tolerance, as you can see, is not as severe as people would think would be because it's morphine. But that is when like even like people in nursing homes and like medical and healthcare fields, they have to be eye looking if someone all of a sudden is catching mood swings out of nowhere, their lack of concentration, and like their physical body really comes depend on the drug. So it's like a compulsive diet, basically. Like it's uncontrollable, like you need it all the time, like you must need it, or you feel like you're just not going to get through. And so that is where like also a body aches, like someone just normally walk without a problem, all of a sudden their leg starts to aching. That's when they know, okay, so it's decreasing high tolerance for you, so now you increase the drug to get into your system, and that's when it becomes very deadly.
Yes. So I believe I mentioned this before, but tolerance to benzodiazepines can develop very rapidly, and cross tolerance can as well. And this is when benzodiazepine is a depressant, and another type of depressant, such as alcohol. If you're already addicted to another one, then that means you are now addicted, or if you already have a tolerance to another depressant, such as alcohol, you'll have a tolerance to the benzodiazepines. Um, and this medication will help with the anxiety symptoms that you're experiencing, but the actual issue that's causing your anxiety is not going away with the medication, of course. So people will continually use this drug and increase their doses to get a stronger effect. And that is how tolerance can quickly develop.
So good news is for patients who become very addicted to not patients, but also people addicted to morphine. It's a very good thing. There is such thing as a 90-day program. So it's more intense than just a 12, like a 12 to 16 step. It's similarity, but it's more focused on detoxing you and giving therapeutic treatments to not to become addicted anymore. So I just gave these 3 examples of 3 different locations that does treat morphine addiction. So medical detox is basically you're literally allowing your body to detox. So it becomes like very, very, very painful with that. And then others, they do offer trauma and addiction therapy to understand why you started and help you heal through it. And in patient programming, basically, it's like trauma addiction therapy, but you are literally have no social life. Like you're not in contact with anybody. You are just there.
And for benzodiazepines, these are depressants, which means that when you are trying to get yourself off of them, people can and have died if they are not supervised well. That's why inpatient programs are ideal. And we have a video here of a psychiatrist talking about benzodiazepine withdrawal that we will play for you now.
In my practice in the past 10 years, for the first time, I have patients now coming to me seeking help to get off of benzodiazepines. And this is very interesting because that was not previously the case. It was me trying to convince patients to get off of benzodiazepines. Now I have people actually seeking out my clinics specifically for help and guidance getting off of benzodiazepines. And one of the observed clinical phenomena related to this is that it is very clear that there is a cohort of patients for whom getting off of these benzodiazepines is extremely difficult. The other interesting piece of that is those are not necessarily the patients who have a history of addiction or even patients who are addicted to benzodiazepines. So it seems to be a subset of individuals with something about their DNA, their physiology, their response to benzodiazepines, which makes coming down and off of them exquisitely painful. And I find that fascinating, right? It's as if, this dependence piece is this whole physiologic phenomenon that we really haven't figured out. Now, granted, some of those patients are addicted either to benzodiazepines or other substances. But again, I just want to emphasize many of my patients who are dependent and struggle coming down and off of benzos have no history of addiction whatsoever. The typical withdrawal phenomena that I observe is, again, the opposite of what the benzodiazepines are supposed to do. The universal symptoms of withdrawal tend to be anxiety, irritability, insomnia, and depression. There's also physical restlessness, kind of a jitteriness, sort of motor tics, and that's sort of the average withdrawal phenomenon. But I have seen a very small cluster of patients who come in with much more significant physical withdrawal. It's kind of really manifest as movement disorders. So they are unable to stop moving. They have arrhythmic jerkiness. And I've seen that go on for patients even after they've come off of their benzodiazepines. So let me just say, I typically do a very slow taper in these patients. I advocate for a slow taper, and I'm happy to tell you, why that is. But I've seen patients who not only struggle in the taper process, but continue to struggle with significant symptoms of depression, irritability, and kind of a physical restlessness that can go on for years. If you think about it from the neuroscience, basically, what do benzodiazepines do? They work on the brain's reward pathway. What all addictive substances have in common is that they have a huge release of dopamine in the brain's reward pathway in the limbic brain. So what happens when people use benzodiazepines for long periods of time, their brain adapts by decreasing their own endogenous or innate dopamine, their own dopamine receptors. So you essentially get like a dopamine deficit state, right? Because you're consuming this exogenous source of dopamine. Now, when people stop using benzodiazepines and stop getting that exogenous source, what they have is a dopamine deficit. And we know dopamine is the neurotransmitter that mediates pleasure. So naturally, people get depressed. And some patients get extremely depressed and even, contemplate suicide. I have certainly seen that.
Okay. Sorry. And then here we just have our sources. And that was just a short overview of the opioid morphine and the depressant benzodiazepines.
All right, everybody. Thank you for watching. Have a wonderful day.